So the treatment included, as I said, injections of this drug, and I'm going to point this out because I'll talk about it a little bit later, but the drug is mixed. It's a difficult drug to get to go into solution, as are all the taxanes. So you mix it in a combination of chromophore and alcohol in order to be able to inject it. The drug is not well absorbed from the gastrointestinal tract. Infusions were given over an hour. Patients had to be pre-medicated because of the chromophore. This particular drug is somewhat noxious to the human body and can cause a significant number of reactions, mostly allergic type reactions. So this was again a standard 3x3 trial design. Patients were started at a low dose. There would be 3 patients at each dosing. Once the patients had gotten through the first 2 cycles, if no significant adverse effects were found, 3 more patients would go up to the next cycle. So it started at 90, increased by approximately 20 to 25% in each group of patients. So through 110, then 135 milligrams per meter squared, and actually that's where we started to see some problems. So there was a dose escalation at 125 milligrams per meter squared. The combination therapy of the 2 that was determined in the first 2 cycles continued through the rest of the cycles. As I said before, if patients were doing well at the end of 6 cycles, they didn't have to stop therapy, they could actually continue. And there are a number who went on to more than 6 cycles of therapy. Patient characteristics, there are 14 patients so far completely evaluable, but there have actually been 17 total enrolled on the study. There are 3 right now in active treatment, so we don't have all the information for those 3 right now. All of those who were enrolled received drug. 11 of those of the 14 are completely evaluable right now for efficacy. 14 have been evaluable, all of them for safety values information. Patient characteristics for all of them are listed in here. And then those that had previously had temozolomide, a fairly large number of them. And then, as you can see, number of relapse therapies very high, which is the usual case for a phase 1 study. The performance status, or how well someone is doing, both before, during, and after therapy, was actually assessed as well. And at the beginning, most children were fairly high. This is a 100 scale, so the 100 would be the highest you could get for performance status. Risk associated with TPI 287 that were actually derived from 3 previous adult studies prior to this pediatric study are actually listed here, and I stole this off of Archer's website to be able to put this on there. Most of them, you can see, are related to pain and neurologic issues. A number of them had bone marrow problems, both red blood cell and white blood cell numbers. I will say that in the adult world for oncology, the adult oncologists care much more for low white blood cell numbers than in pediatrics. They get very nervous when neutrophil counts are less than 1,000. To us, that's a great number, so a little bit of a difference in what your perspective is. Arthralgias, myalgias, again, more muscle neurologic problems were associated fairly commonly. Uncommon, nausea, vomiting, cough, and then there was one gastrointestinal bleeding issue that occurred in the early studies, so that was listed as a rare problem. As noted before, allergic problems secondary to the chromophore are a big issue. However, they were not a big issue in the pediatric trial. For the safety data, in the early phase, there were 3 dose-limiting toxicities that were noted. One at the 110 level, which was a seizure, which was thought to be possibly related. There were an additional 3 patients treated at the 110 level, and no other dose-limiting toxicities were found. So at the 135 level, there were actually 2 noted in the first 2 patients at that level, and so there was a dose de-escalation down to 125 milligrams per meter squared. EKG issues are thought to be a problem with a number of the taxanes, but no issues have been seen in any of the pediatric trials or actually in any of the adult trials. No decrease in neutrophil counts that were significant were seen in the pediatric trial, different from the adult trial. No toxicities once the addition of temozolomide was added, other than having some problems with a little bit of bone marrow suppression early on in the weeks. And then the common toxicities, again, were seen the same in the adult trials. As I said, the maximum tolerated dose was found to be 125 milligrams per meter squared. All of the different problems that were found in the first 14 patients is listed here. And as an overview, so of the 14 patients, 11 of them were evaluable for response. 7 of the 11 had stable disease, and as we've talked about before, that actually is a very powerful thing, especially if the stable disease lasts a long period of time. 5 of 9 patients entering this disease who actually had progressive disease while starting had stabilization of disease. Overall progression-free survival for all of the patients, 125 days, and we'll talk about that in a second. Those who had stable disease starting therapy had over half a year of stabilization of disease while on trial, and those who had progressive disease, their progression-free survival was actually fairly low. So with a phase 1 study done, and now a few more patients need to get enough data from it, but we have a maximum tolerated dose figured out for children, what is our next proposal? So we plan to go on to developing 2 trials in this particular drug. The first is a phase 1/2 trial of TPI-287 in patients with refractory neuroblastoma. This will be NMTRC 004, which will be chaired by Dr. Parak from in Connecticut. It'll be an open-label multicenter trial. There'll be a phase 1 portion to actually assess a new formulation of TPI-287 that has much less cremophore, a 15% cremophore, which will actually decrease, we think, any potential problems from the drug. The phase 2 portion will then assess activity of TPI-287 based on overall response rate and looking at complete and partial responses. The secondary objectives, as are true for most of the studies, will be to look at how long progression-free survival we get for patients with disease, overall survival as well, and what people call clinical benefit, which is the 2 of those combined. We'll continue to monitor for safety issues for patients with refractory disease. We'll evaluate, again, pharmacokinetics in this particular session. This particular trial is going to be a little different than the previous one. We plan to decrease the timing of the disease, the infusion of TPI. In the phase 1 study, it was given weekly for 3 weeks, but then a week off. In this particular trial, it's going to be weekly alone, though there won't be an additional drug added to it. This will be open to patients who've had multiple relapses. And then we'll again plan to collect biological samples. So the first 6 subjects will be part of the phase 1 study. They'll get the dose compression from 28 days down to 3 weeks to assess to be sure that both the MTD is correct when giving it weekly with no breaks in between, as well as the new drugs, the new combination. They will continue on for all 6 cycles of the therapy. If the MTD is confirmed, the phase 2 portion will open, and this will be divided into 2 different stratums. A number of studies through COG and other cooperative groups have started to split up patients based on location of disease. The stratum 1 will be patients where you can actually see solid tumors by CT or MRI scans. Stratum 2 will be for patients where disease is either limited to bone marrow or bone disease, only seen by MIBG scan. There appear to be biologic differences when you see this in outcomes based on other studies. Patients will receive treatment based on the phase 1 portion. We're planning to use historical controls for this particular study and not do a randomized trial for this. The COG recently defined 42 days as a standard for comparison for progression-free survival in a recent study, the ANBL 0621 study. This was a group of patients taken from previous trials of phase 1 and phase 2 studies done through the cooperative groups that looked at how long progression-free survival was for those patients. And those are the studies that are listed. All right, so the last study, randomized phase 1/2 study for using irinotecan temozolomide and comparing that to irinotecan temozolomide and TPI-287 in patients with refractory or early relapse of neuroblastoma. This is going to be an randomized, open-labeled, multi-center study. Again, there'll be a phase 1 portion to be sure that the maximum tolerated dose is adequate for this particular group of patients with combination of adding yet another drug onto our particular therapies. The phase 2 portion will be to determine the overall response rate, complete and partial responses in patients comparing irinotecan temozolomide to the combination of all 3 drugs. The secondary aims, again, will be to assess safety. We'll plan to monitor for progression-free survival, overall survival. A big part of this is we want to start assessing for quality of life for children going through treatments. How well are they doing through all of their treatments, which will be an upcoming focus of most of our upcoming trials. And then we want to explore the relationship again of tumor types. The phase 1 portion, again, will include the first 6 patients. If those patients all show that using the maximum tolerated dose of 125 milligrams per meter squared with the combination of the 2 drugs with this is adequate, then we'll move on to the phase 2 portion. Here the patients will be randomized to receive either irinotecan temozolomide, which in a recent phase 2 study through the Children's Oncology Group did show significant benefit to children with neuroblastoma. And we'll compare that to now our experimental arm of irinotecan temozolomide and TPI 287. For patients on Arm A who progress, they will be allowed to switch over to Arm B and then actually complete a total of 6 cycles if they get benefit. So all the children who are in the trial will be eligible to receive the experimental drug with the exception of those who get through irinotecan temozolomide all the way to the end of 6 cycles. And then just a quick schematic of what it actually will look like. Patients will be assessed. The first 6 patients will go on through cycle 1, phase 1. If there are problems with the maximum tolerated dose, we'll then have to reevaluate, but if not, we'll move on to the phase 2 portion and randomize patients and move them through this. And that's it.